Hello, friends. A warm welcome to Indian Association Bronchology's online thoracoscopy certification course. As you all know, it's a very different initiative taken by IIB. And over here, the entire certification course consists of 10 online modules, followed by 4 physical workshops in different parts of the country on different days. To get the certification, you need to attend at least 8 out of 10 modules and any one workshop that suits you, that's close to your place, and it also suits you date wise. And at the physical workshop, you'll be given the certification. For today's module, we have a galaxy of stars who are our faculty, very esteemed, very learned faculty who've been doing fantastic work in the field of thoracoscopy. And to moderate today's session, we have actually the emperor of thoracoscopy, none other than Dr. Jayachandra. Dr. Jayachandra requires absolutely no introduction at all. He is one of the pioneers in thoracoscopy when it comes to our country. I feel probably he might be the first person to start thoracoscopy. He started thoracoscopy right back 30 years back when I had not even taken up medicine. So you can imagine he is actually the father of thoracoscopy, the godfather of thoracoscopy, I should say. He's a king of interventional pulmonology, which is his passion. There's nothing in interventional pulmonology that Dr. Jayachandra doesn't do. And he's been a teacher to so many of us. I mean, he's somebody we always look forward to listening to. We always look forward to meeting because he's such a nice person. And I would like to say that he's a great friend of mine. So he is a consultant and director and head of the department at the Hyderabad Care Hospital, Banjara Hills. He was the first in our country to do the National Thoracoscopy Workshop. And I believe everybody who knows thoracoscopy in our country have been taught by him at some stage or the other. And there's just so much more. I mean, so many publications and so many textbook chapters and so many other things to talk about. If I start talking, I'll go on till tomorrow. So I think I'm going to stop right now. Over to you, Dr. Jayachandra. We look forward to an excellent webinar today on complications of thoracoscopy. Thank you.
Thank you, Amita. I think that was very kind and a very warm welcome, I should say. And coming from you, I think I really like it. Thank you. I think you've just gone overboard with the introduction, but then I leave it to you. That's okay. Anyway, I think much more than individuals in this particular thing, I think we've got a great program which has been set up today by IIB. And this is only part of the initiative in teaching people thoracoscopy, very formally structured program, which is going to go on over 10 sessions, if I remember right. Each one dealing with one particular aspect of thoracoscopy, especially the theoretical aspect of it, and just about the elaborate issue in this present instance of today. That is, we're going to talk about complications of thoracoscopy, pitfalls, the challenges, how to deal with them. I mean, we have great people to talk about it, people who have been doing this for a long time. I mean, both of them, incidentally, I have known them personally for a long time. Sandeep Nair from Delhi and Nagarjuna, of course, is our guy from Hyderabad, one of the stars from Hyderabad. Now, I think I need to formally introduce these guys. Sandeep Nair, he's one of the very early guys who thought, we need to do something in interventional pulmonology. He was working with another friend of mine, I believe Dr. Rajiv. He was working with Rajiv. Rajiv is also a pioneer in IP and thoracoscopy and other things. I mean, he's another well-known figure. But Sandeep went on. He went on to Brussels, he went to Marseille, he went to all these things and formally got trained in interventional pulmonology. Now he's a well-respected and a senior guy in Delhi, working, I'm sure, with a lot of interventions to his credit and running a very successful practice, I'm sure. Talking about Nagarjun, Nagarjun is again from here. He is graduated from Jipmer Pondicherry, then went on to PGI. He thought that was a little better institute. And I heard rave reviews about him from PGI, colleagues of mine who told me that he's one of the bright stars in our PG courses. He's one of the brightest guys. very hardworking, very dedicated, very intelligent. And I'll tell you one thing, he's lived up to his reputation once he's come back to Hyderabad. He works with Yashoda Hospital right now. But I think Yashoda Hospital is little richer because he has joined them and is contributing so much to the hospital by way of pulmonology. He's started some specialized clinics for ILD, COPD, asthma, and what have you in general pulmonology. And needless to say, he's a skilled interventional pulmonologist. He does everything. Probably he's the first guy who started doing this thermoplasty, well, which went out of the window now, incidentally. But then, it's not what is current. It is just that he was always in the forefront of developing new technologies, getting them available for his clientele. So I think he has done a lot of work in EBUS. He has done a lot of cryobiopsies. These have become very commonplace now. But I'll tell you one thing. Doing these things in the initial phases, where nobody else is doing it and when you have no other support systems available, that takes a lot of guts and it takes a lot of courage. And I think Nagarjuna has done it all. So instead of going through with all the written down CV of Nagarjuna or even Sandeep for that matter, I deviated from the text because I know them personally. I thought a personal test would be much better introducing these people than going through a very structured CV. So let me not take any more time. And I think I will invite Sandeep to go on with his talk talking about the pitfalls, challenges facing medical thoracoscopy, how he views it, and let us hear his perspective to this commonly done procedure in pulmonology these days. Theory, you will find it anywhere. Personal experience is rich, and I don't think you can replace Sandeep in talking about all these challenges. Over to you, Sandeep. Sandeep, you need to unmute yourself.
Thanks a lot, sir, for the kind words. And my slides are visible, sir? In this module making, because we are having a detailed thoracoscopy modules, and just imagine a whole day being dedicated to a complication and pitfalls, because otherwise when you have a workshop you just have a 15-20 minutes of the complication and that's it. So we are going to have a detail of each and everything, which is a very nice way to go about it. And of course, sorry, this is not moving. Yeah. I hope it's moved. Yeah. So before I come to really the pitfalls or the complications, just once two slides about the indication, the contraindication. We've already talked about it, but unless you know about it, you will not know what you're doing wrong. So indication, of course, quickly we know what they are, but the more importantly when we talk about it are the contraindication, when we should not do the thoracoscopy is something which is more important than sorry, the slide is not moving. Just a second. Yeah, sorry. Okay, so it's more important to know when not to do it, because like Dr. Jaya, our senior, was saying it, that this intervention terminology, when we talk about it, I still remember the golden words. It's not what you do. You should know when to stop and what not to do rather than doing it unnecessarily. So you should know about the contraindication of this patient. You don't have to go ahead and do a microscopy if the lung is adherent to the chest wall, because there's no space to do it. Even the hypercapnic patient or uncontrolled cough, because patient will not stop coughing, and where you going to find the space, or even lack of consent. So these are all elective procedure mostly. And until you have had a consent from the patient, there's no way you go ahead and do a thoracoscopy. Then there's some relative contraindication. Look at this lung, which is a trapped lung. Then if you're doing a thoracoscopy in the patient where the lung is not expanding, then definitely it will be a challenge in doing it. Of course, there will be in odd cases where you may have to do it because you have to approve biopsy to know about it. But those patients where the lung is most likely not to expand, for example, a patient of ILD which has got a stiff lung, or a patient who's got empyema and a thick peel on it, or even the patient has got a central tumor where it will not allow the lung to expand. So there it will be always a challenge to do a thoracoscopy. Of course, in the patient who are very obese, or the patient who have got some comorbid condition like ischemic heart disease or recent MI, you may have to delay the procedure for some time and then do it. Even the clotting dysfunction was, of course, for example, the platelets are very low, but we normally do a thoracoscopy if the platelets are about 50 to 60,000. And even if the INR is about 1.5, less than 1.5, we are able to do it. So some clotting dysfunction can hinder you from doing a thoracoscopy, or a patient with renal failure because they tend to bleed more, or a severe hypoxemic patient. Because the severe hypoxemic patient will further be hypoxemic when the patient is made to lie on one side of the lung with a healthy side down, because you are treating on the unhealthy or affected lung, and then that also you call the pneumothorax when you are entering the with your thoracoscope, so further compromising the lung status. So these are definitely will be a challenging to do thoracoscopy in the hypoxemic patients. So before I go ahead, my request to each and every my colleague and the people who are watching it, just because you want to do a thoracoscopy, just don't do it without even telling that even the pros and cons to the family. Explain it in detail with the family as well as the parent, as well as a patient, because there's no point in doing any procedure without making them discussing with them, taking them into confidence, because God forbid if any complication occurs, at least they should be aware of that this could occur. So I hope it never occur with anyone, but please discuss each and every details with the patient or the family. Very importantly, because you want to prevent the complication, you want to prevent the problem you might face, is a pre-procedure checklist. You have to go through it, a good medication review for the patient, what he's been taking, what he's not been taking, or what he has to stop it, maybe on some anticoagulant. You have to do some basic laboratory tests, the CBC, PT, INR, like I said, the INR of more than 1.5 will be always a challenge to do a thoracoscopy, so it should be less than 1.5, and some people even say 1.2. The CBC count should be there. The platelets, again, like I said, 50 to 60,000 should be minimum platelets, because this might prevent bleeding. KFT is very important because the deranged creatinine and the burn can cause bleeding even despite having a normal platelet and INR. More importantly, the chest imaging is very important. You get a image of the patient. The chest X-ray is not enough. You may require a CT scan or even ultrasound of the patient. You want to know, quantify the volume of the fluid, and if so, also you want to know where exactly you are going to aim. And informed written consent, I will again and again say, is very important. And then you have to have a patient fasting for at least 6 hours. And you have to really check each and every part, because the patient might be on anticoagulant, and like it has been shown in the screen that you have to stop this anticoagulant depending on which anticoagulant is he on, whether he's on clopidogrel or warfarin or dabigatran, because many of these elderly patients which we encounter with the problem of the lungs might even have a problem with the heart, because many of them are smokers, they're having malignancy, they will be having CAD, and then CAD the patient might be on some anticoagulants, and then they come to you with the malignancy where you want to do a pleural aspiration and followed by thoracoscopy. You should know that they're not on an anticoagulant. At the same time, I would also like to request to please know about the diabetic status and the hypertension, because many of the patients who are diabetic, they might be taking some anti-diabetic medication, and when you call them, you have to do this procedure empty stomach. They will come to you and they've taken an insulin without knowing that they might go into hypoglycemia. You're doing a procedure. So please, if they've taken a medication and they've not eaten anything, they may have to give them a neutralizing grape or something, because you don't want a hypoglycemic patient sitting or lying down in front of you and using a procedure in it. Similarly, on the other hand, if the patient is having hypertension, if they're not taken a medication and they come to you, sir, because you told me not to have anything, so I've not taken even my antihypertensive, and then the BP will shoot to 200 by 120 and doing the procedure, and by God forbid there's any bleed, it will not stop. So please, small thing, you please take a detailed history of the medication, and then you subject them to for a thoracoscopy. And before you go ahead, please look into your instrument. Do check your instrument. It's immaterial whether you're doing a rigid or you're doing a flexi rigid. Please check your instrument just before you take your patient, or you even drape your patient, or even you wash your patient. Just see your biopsy forceps. I'm just checking my biopsy forceps is working or not. I don't want to give a lick and go inside, and suddenly I see my biopsy forceps is stuck, and I'm stuck up, and I don't know how to go about it. If you have to do a lot of suction, is a pleural effusion. Just see, this is a trumpet suction which we have it. That of course that we can suck it out. If we're expecting a pleural adhesion, we should have this hook. Many of them we have it so that we can break the adhesions. Check out our trocar, so that before we go inside, our instrument should be always checked. We may even have to do a pleural disease in few patients, and whenever we want it, we see that our apparatus is there, our calc is ready, and we see that we can insufflate it. The bulb is working well. I remember once this bulb was punctured and we were pressing it, it was not going. So please check it out. This is working well. Before you go inside, before you start doing your procedure, please check your instrument. This is very important before you go ahead. These are small things which we normally miss it, and I hope that we do it by checking it out. Teamwork is very important. Like interventional pulmonology cannot be done alone. Let me honestly confess it. I cannot do with my team, or whether my senior or my junior or my associates. I have to have a team for doing any intervention. So you have a good understanding among your teamwork. So if anything goes wrong, everyone knows what to do. If there's a bleeding, who everyone knows who is to put in a adrenaline or a sponge dipped in adrenaline. It comes automatically. Of the patient, the BP starts falling, or the pulse starts falling, or the saturation starts falling. The who is going to take care? So your teamwork, your understanding is very important, not only with the doctors, but even with your colleagues, even with your technician, your nurse, staff nurse. Everyone should know, and a good understanding is very important. So whenever you are doing a intervention, I always try love to do it at my own setup, whatever good or bad it is. I know I can always, there's always a helping hand, and I know whom to fall upon if anything gets stuck up. So a teamwork is very important when you go ahead and do a intervention. We make it a point, we do an ultrasound even on the table, because we have a luxury of having an ultrasound table, ultrasound in our rooms. We can even call our radiologist if need arises. So this, we are checking it on this patient, and we mark the place where we have to do, which is the best way to enter. Those places who don't have an ultrasound in their room, because it needs every PMDT, everything, allowance to get it in your setup. So those people, please do an ultrasound just in the morning or a day before. Not he's done it about 1 week there or 10 days there, because you might find a different scenario. So please do an ultrasound, and importantly, don't do an ultrasound in the sitting position. Do an ultrasound in the position in which you're going to do a thoracoscopy. So if you're doing on the right lateral position, because left side is affected, do an ultrasound in the right lateral position only when you go for an ultrasound, and mark it out. Like I just showed you, we mark it with a needle in these patients. If I can show you again, that this is how we mark it. We mark it once we know what is there. We just mark it with a needle cap. One can do with anything, but not with a ballpark, because once you wash it or drape it or clean it with the spirit and betadine, it will go away. So this is very important to know where we are doing it. I'm using most of the time rigid thoracoscope, and camera is attached on it, and the camera is mobile. It can rotate into 360 degrees. So please see that you are perfectly oriented Just see your anterior is anterior and posterior is posterior. You don't want to go in and then you forget it where the anterior was or where the posterior was. So please check it before you going inside. This is just before we are going inside. Everything should be done. So having said that, now we are set to do a thoracoscopy. I'll not go to the steps; it's already been done in the previous module. But despite taking all the precautions, despite doing all what you can do best, still some problems, some complication can occur. And this is what we are going to discuss it out today. There may be fever, pain, pneumothorax, subcutaneous emphysema, and so on and so on. And let's divide it, all these complications broadly into the complication before the procedure, during the procedure, and after the procedure. Before the procedure, complication which can occur, that air embolism can occur, especially when you're introducing a pneumothorax. If the patient has got a small pneumothorax or small effusion, you may have to increase it space because otherwise you won't be able to enter. And while doing it, you may cause air embolism or subcutaneous emphysema. You have to be very careful. I'll be showing you in the subsequent slide. The patient might have shortness of breath or hypoxia during pneumothorax induction. The patient may be hypersensitivity, hypersensitive to the local anesthetic. So please be very careful when you're giving a lignocaine because patient may have be hypersensitive to it. During the procedure, patient can have pain, hypoxemia, hyperventilation. These all can be taken care of, which I will be talking in the subsequent slide. So even arrhythmias can occur, hypotension, hemorrhage, anything can occur during procedure. But please be aware and careful about it so that the necessary precaution is taken so that even if the complication arises, we are able to tackle it. After the procedure, also patient can have some pain or post-operative fever or a wound infection or hypotension or empyema or prolonged air leakage. All these complications you must keep in your mind. And now I'll be just discussing it in detail of the complications which we normally encounter it. Of course, numbers can be varied in this study. Normally, the most common complication we encounter is the subcutaneous emphysema, but they're mainly very small and they are usually, absorbed on its own. You don't have to do much in it. Patient can have pneumothorax and fever. These are the three commonest complications which we encounter, but you can have dyspnea, tumor seeding, empyema, many other complications also. And when we classify this complication, if we classify it as the endoscopy is classified in the grade 1, 2, 3, 4. The one is a small complication, not life-threatening, no residual disability, just like a pneumothorax, a small subcutaneous emphysema which goes away. There too are when we actually require an invasive procedure to manage a negative outcome. And once you do it, it is taken care of. For example, if the bleeding, you stop the bleeding, then there is no residual disability. Grade 3 is when appropriate management has been done, but there is still some residual disability is there. The patient has bled a lot and is under shock, and you even taken care of the problem, but still there will be some problem with the patient. But grade 4, unfortunately, is the last, the most serious one, which is the fatal complication, which is very, very, very rare. And if you really go by the great studies which have been done in past, someone has done a 2,500 patient or 2,600 or 566 studies, you see the grade 1 maybe 1.6%, but grade 2, 3, 4 hardly any complications. So this is a very safe procedure when you do it. If you're properly selected patient and proper, if you've taken all the precautions, so this doesn't cause much complications. Now, one of the common complications which may occur is pain or a post-operative fever. And when I talk about the pain, we have to start right from the word go when we are taking this patient. A good local anesthesia is very important when you start doing a procedure. Not only the wheel is raised whenever you selected the site, you even go deep and keep on withdrawing and injecting the lignocaine, and you see that the whole track is anesthetized, the subcutaneous tissues, the skin, and as well as the pleura. Pleura is very sensitive. The brighter pleura is very sensitive, and the patient feels pain when you pin it, when you prick, when you cut it. So please be very careful when you are entering the brighter pleura. And good anesthesia is very important. So when you give an incision, the patient doesn't have a pain. You have already checked it with the needle marks. And this again, when you're giving an incision, it should be just the skin not deep, because the deeper you have to open up the whole space. You don't have to give a deep incision, because that will, if you give a deep incision, that will cause more harm than help. So just opening up the track will help you in many ways. There will be no blood. It will be almost a bloodless entry. Second thing is, when you enter your port thoracoscope, it will the subcutaneous tissue will almost oppose that place, so there will be no leak or entry of the air. So you have to just open up the track. You don't have to give a very deep incision. Patient may even have a post-operative fever, and the fever which normally occurs are predominantly two causes. One is, of course, infection, the other is inflammation. The infection normally occurs when you don't want to, but still you have in the past of the infection, because probably you have not taken a full care while cleaning or sterilizing your instrument. There can be a wound infection where you're giving a nick, or probably the blade was not sterile, or maybe you've touched it with unsterile hands, and you can even lead to empyema, empyema in these patients if you introduce an infection within the pleural cavity, which was sterile to begin with, but because infection is introduced, and it may result in empyema. Though it's very rare, but it can occur, and sometimes even lung infection can occur. But you can definitely prevent it. You can prevent it by a proper, suitable endoscopy room, which should be absolutely sterile. We do it in our bronchoscopy suite, but thoracoscope needs even more sterile condition as compared to your bronchoscope. So bronchoscopy you can still afford to some extent, but not in thoracoscope. It has to be absolutely sterile. Proper management of drainage should be done. When the fever is there, you please see that cytological and microbiological analysis is being taken. Some may even advocate the usage of antibiotic prophylaxis in few patients, and we also give a shot of antibiotic just before the procedure is done, just to for prevention. The other cause of fever is inflammation, which may normally occur, and that's normally seen when you are predominantly seen when you're doing a thoracoscopic talc porterage, and because when you are insuffling the talc, this leads to inflammation, and that's exactly what you want because of the pleural disease. And once this is the porterage is done, patient may have fever starting from as early as 4 to 12 hours following the talc installation, and can may even last to 3 days or 72 hours after completing your procedure. So you have to warn your patient, you have to tell your patient that the fever may occur, might occur, and then you may even have to give antibiotic to these patients. At this point, I must also talk about that talc pleural disease. When you are doing it, you have to use a Steritalk or a talc because there has been reported cases of ARDS. When they went into the literature, they further found out that that was because of the smaller size of the talc particle, and if you use it as the graded talc, which is the more than 40, 35, 40 micron, the chances of ARDS is almost zero. So you have to prevent the ARDS also when you're talking about talc pleural disease. The inflammation, of course, is fine, that can occur, and that's not a very troublesome problem. You can take care of giving antibiotic to these patients. Another problem which you may encounter is the pneumothorax or the subcutaneous emphysema. If you see it, you can see this is a subcutaneous emphysema. You can also feel it when you touch it. You will feel the capitus feel. Here is a very small. This thing has improved. Is a small pneumothorax now left. So it normally absorbs on its own. So don't worry about this subcutaneous emphysema. Mostly, it will be taken care of, because this normally occurs when there is a passage of air in the subcutaneous tissue, either from the thoracic cavity or from the outside, or maybe the secondary to the malfunctioning of the vacuum system. So this pneumothorax or the subcutaneous emphysema can occur. Other reason can also be occurring, can also cause subcutaneous emphysema is when you're putting in a chest tube, and then any eye of the chest tube, the whole of the is within the subcutaneous tissue. So whatever is inside, the air is inside, especially the pneumothorax, the air starts coming from the chest tube, and from the eye can go into the subcutaneous tissue and can cause subcutaneous emphysema. So you should know that you have to, when you're putting your chest tube, it should be deep inside, so that no drainage holes are left in the wall, and the internal hole should be very small. That's what when I told about the when we were talking about the incision. that when you're giving an incision, it should be only till the screen. Just you just try to open it out with the artery forceps so that the inside hole is very small. It opposes whatever you are putting in, whether thoracoscope or a chest tube. So it almost they can apply like a cushion around it so that there's no leakage of the air. So this is very important whenever you are making an incision because you don't want a subcutaneous emphysema outside. Be very careful when you're dealing with the patient of pneumothorax because when you go inside, you might see a bleb or a bulla, and be very do not touch it, do not try to fiddle with it because you puncture it. There'll be prolonged BPF and leak will be there, and these bulla takes time to recover or heal. If at all they recover, some of them might not recover and you will be requiring a surgical intervention. So be careful when you are watching it. Please see how the bulla or the bleb looks so that next time when you go in, don't touch this or don't take it until unless you've really prolonged it. Because as beginners, I would request, or many of them will be the beginners, that please, the lung is not our domain. Of course, when you've done enough number of fluoroscopy, then you may go and do a lung biopsy. But to begin with, the lung belongs to the surgeon, and we stick ourselves to the pleura only, that to a parietal pleura. So we don't take lung biopsy when we're starting our thoracoscopy. Another dreaded complication which we are always feared of is a hemorrhage or hemothorax or a bleeding which occurs from the parietal biopsies. It is the most feared complication. It can occur at any operator action. It can occur during thoracentesis. It can occur when you are inducing a pneumothorax. It can occur even with a skin incision or introduction of the trocar, or even when you are trying to detach the adhesions. You're taking a biopsy, you're taking a biopsy from a vascular part, and you take it out, or you're not taking it properly, you have punctured the intercostal artery or vein, and then this is a place that we have to be very, very careful whenever we are doing our thoracoscopy. It's a very dreaded complication. Be very, very careful when you are going inside. I was this patient when we were doing thoracoscopy, these had a lot of adhesions. So we have to really clear the adhesions very, very carefully, And this is another patient where we had to do a biopsy because a lot of adhesion we were able to go inside by somehow, and we took a biopsy from the pleura. So these places when you're doing it, the adhesion should be clean before you really go to the parietal pleura, because these adhesions can really trouble you a lot, and many times you have to just stop it and see that because they're so soft, so tough that you do just a biopsy and come out because you know you're not able to break all the adhesions, and these adhesions cannot be picked up many times, not even in the CT, not even a ultrasound many times, and when you go inside you find really cumbersome position. Whenever you're doing a pleural biopsy, again, be very careful. This patient, we took a pleural biopsy, it bled a lot. You can see a clot now, then, but fortunately it was stopped when we took another biopsies also. But sometimes these biopsies are tend to, bleed. So we have to be careful while we taking these biopsies from the patients, especially those who are using the vascular tumors. So what precaution we should take? Where biopsy should be taken? We can take it on the diaphragm, but we should never take it from the parasternal because we may injure the internal mammary artery, and then the bleeding is really bad. The safe zone always remains in the parietal and the posterior aspect. Never take a biopsy from the lung as a beginner, but even those who are taking, please avoid the fissures. And when we are doing a biopsy, we always test the ground before we take a biopsy. Avoid the sharp and the point of press, and only gradual pressure should be applied. And normally we should take a smaller biopsy, and it should be a pinch and peel. We should not go deep and biopsy which we take it into deeper biopsy. We should not be doing it same in the thoracoscopy. It should be a pinch and peel biopsy. And like I said, avoid interior parietal pleura because there are the dural vascular vessels, you might injure it. Posterior parietal pleura, you may go ahead. And this is how I take a biopsy. If you see this peeling biopsy, I always test it. I always try to take it on the rib. And if I see this is hard, I take it on the rib. But if not, I can take it just above the rib, but never, never, never below the rib, because that is the place where the vascular vessels are there, and you might puncture it. So see, if you see, I'm tapping it and see, yes, I can see the hard surface. So I've taken a biopsy from there. Sometimes you have to take 2, 3 times because you missed an audio. But this is how we take a biopsy. You just feel that yes, we are hitting the heart surface, and probably be on the rib. So this is a safe place to take it. So avoid apes, mediastinal, pleural, internal memory artery, because that is a problem where we might hit it, and you may sometimes injure the intercostal vessels. So you have to be very careful. For example, this lesion, you see that here the intercostal bleed is very less. So just pressing on it stops it. So if your pressure is applied, so this is very small bleed. So most of the times it stops on its own. Very rarely you have to apply a gauze with adrenaline, or you have to thermocoagulate, or just mostly it stops it. And so just keep calm, and just try to remain calm. All of your team is looking upon you, and you have to really have a teamwork, and you have to don't cause panic among themselves or yourself, and just try to do it. Unless this patient this was really bad, and this I must thank Dr. Vijay, because this happened with Dr. Vijay, who is in Hyderabad. He was nice enough to provide me this slide, and this happened when the biopsy was being taken. Look at the way it is bleeding. This is internal this is the intercostal artery which has been punctured. And once the intercostal artery was being punctured, see how it bleeds. So again, like I said, you have to be very careful. You may even require a second port in this time, because mostly we do it as uniport or single port thoracoscopy, but many times we have to introduce in the second port also, especially if you have to take a lesion on the near your port where you have entered. If the lesion is on the same side, you have to take a port from the other side and take a lesion. Here you have just pressed it with adrenal gauze, it has stopped it, and if at all is still there, you can just thermocoagulate it. So sometimes you really are taken by a surprise, and you are punctured the intercostal artery, and many times you are unlucky, because there may be some aneurysm in the intercostal artery, and there are reports which have shown it, and unfortunately if you pressed it, this AV fistula or aneurysm, it might lead to cause a lot of problem to you. So that is a very rare case, but it can occur if you're doing your when you're taking a biopsy. Tumor seeding is something else, which something extra which we normally see. Tumor seeding is not very common, but this is can be seen, especially in the case of mesothelioma. And it has been seen that when you're taking a biopsy from the mesothelioma, there can be seeding of the tumor, and as high as even 10% have been reported in few of the literature. And then they say that many of them, they advocate that as soon as you take a biopsy from the mesothelioma, turns out you may even have to give a radiotherapy in the tract, so that to avoid having a tumor series. So prophylactic, some people advocate giving the radioactivity in these patients. Lung perforation again is another problem which may occur, especially in these patients who have got a which have got a low space, very small effusion or a small pneumothorax, and you've entered and you have punctured it out. But it's again a very, very rare when you actually see perforation of the lungs. Normally, it is mainly seen in the patient who've got adhesions in the pleura, especially when there's not much space in the pleural cavity. We should be very careful introducing the trocar. We may even have to use a coagulant instrument so that we can coagulate it. Suction is not required. Many of them do heal on the gravity. But whenever you're anticipating there will be less place, you must introduce it. And there's a guideline very clearly said that whenever you're going in the pneumothorax, it should have at least 100 to 200 ml of pleural space, so that at least 2 centimeters away, the lungs is away from air, because when you're entering a trocar, you don't want to hit it. Of course, the large amount of pleural effusion, you can directly insert the puncture sheet, but in a small effusion, you please introduce some air or even saline. Some people do that, and to cause enough space when doing it. And if there's a lesion, you may even have to break it before start doing thoracoscopy. And of course, if there's no space, there's no way you will go ahead and do thoracoscopy. And this is how it should be done. You may even have to create an artificial pneumothorax at times. This is our patient who had a very small pneumothorax, and you see this is what we are doing it. And if we can see clearly, I've just enlarged it also. So we are introducing the air through a 50 ml syringe with a three-way, and gradually, and we are doing it under ultrasound guidance. That's how we do it, because we actually see the pleura going away, the lung going away from the pleura, and then gradually this space is filled with the air. So we do under ultrasound guidance. If you can see, this is a probe, ultrasound probe. This is the probe which we have it, and under the guidance, we are introducing the air into it with the 50 ml series and three-way. You can even use a botin needle for the artificial pneumothorax, because you need enough space before you go ahead and do a thoracoscopy. So this is what we do before we go ahead if the pleural space is small. Of course, there can be some cardiovascular complications which are not very major. You mainly take out because you have already taken care of it as a prerequisite or a pre-op checklist. The patients, but still sometimes go into bradycardia, especially hypertension when you're introducing a thoracoscope. Sometimes even a re-expansion pulmonary edema can occur if you're gradually, rather than removing a fluid or you gradually remove it in a fast. I will just show you in the subsequent slide. But again, there can be some ECG changes or arrhythmias, but most of them are can be taken care of. None of them are very dreaded mostly. Re-expansion pulmonary edema is very important, which we will always keep in our mind. You can encounter these problems, especially you are taking out the fluid very fast, you are taking out the air very fast, it will cause vagal reaction. So the risk factor is depending on the chronicity of the collapse. If the collapse has been there for quite some time, the volume is too much, or then if you would really take it very fast, there can be a re-expansion pulmonary edema. You can see it one side of lung, how it looks. And you should be careful when you're doing thoracoscopy in the massive pleural effusion. For this example, this is the case. This is the X-ray on 13/12, just 4 days back, 3 days back, when we were called. This is a malignant patient who wanted to do a patient. We want to do a thoracoscopy with pleural disease. So what we did, this is one of the things which we can do. I aspirated some fluid about day before only, so that because patient was dyspneic, at least some dyspnea will be removed, and they will less chance of re-expansion pulmonary edema. Or you can even remove it on the table. And you put in a catheter, try to remove it out. But whenever you're removing it on the table, let some air go inside. So you leave a space, you leave it some time so that air goes in, it can be sucked in. So that fluid which we have taken it out can be replaced by air. So the chances of re-expansion pulmonary edema is less in these patients. Very rarely air embolism can occur, but that is very unusual. But it has been reported in literature. You can avoid it by especially when you're doing artificial pneumothorax. You have to be very careful. It can cause air embolism because you may introduce a needle rather than bronchi. You may introduce it in the nearby capillary or the venular and can cause air embolism. And there has been reported literature also about the embolism. And lastly, you don't want it any death of the patient. It's a very rare, but there has been reported in the literature. See, if you compare it with the transbronchial biopsy, the thoracoscopy, the complication of thoracoscopy is much lesser than the transbronchial pulmonary biopsy which we take it. So because the mortality rate is just 0.09%. So it's a very safe procedure. So the lastly, I would like to conclude that just because we're speaking on complication, it doesn't matter that we want to deter you from doing a thoracoscopy, we want to scare you. It is just we want to you to be aware of the complications so that it doesn't occur. But if you evaluate a patient and you see that there is no contraindication when you're taking this patient and there's suitable environment and the instrument, you will definitely be able to avoid all the possible complications. You have to monitor these patients when they are being taken for the thoracoscopy, because otherwise this is a very safe procedure and free from any major complication. So with this, I would like to thank you for each and every one of you, and especially to Dr. Amita and Dr. Jayachandra and everyone, and I'll be open to all the questions. And this is how the complication should be avoided. And in case it occurs, we have Dr. Nagajan who will be telling us how to take care of it. And or very rarely we may even require a surgical help, because if the patient is bleeding and you get stuck up, then it's a good thing to have a good rapport with your surgeon, have a good friendship. You will never know when he or she may be required. But fortunately, I've been fortunate enough and never have been needed his help during my procedure. I've been able to, if at all the complication occurs, we've been able to tackle it. But still, there will be one-off case, and we should be aware of. Thank you.
Thanks, Sandip. That was a very comprehensive approach to medical thoracoscopy and how to do a safe medical thoracoscopy. I mean, that's the bottom line. We need to be aware of all the complications, yes, so that you can avoid them. But I'll tell you, eventually statistics will catch up with you. So it is better that you're aware of all the complications and know how to deal with it. I think you've dealt with it very comprehensively, and I think you've covered most of it. But then we're going to have another speaker who's going to talk about how to do it if you really land up in a problem. How is it that you're going to look into it? I think you have a very nice qualified person to talk about it. So over to Nagarjun now to tell us about the rest of the thing, anticipating and managing, and how to make it very safe for a patient. Yes, over to you, Nagarjun.
Thank you so much, sir. So before I start, I should thank IAB, Dr. Amita Madam, for this opportunity, and also to Jayachandra sir for the kind words of introduction. In fact, sir was one of the people whom I always looked upon to when I was starting my career in interventional pulmonology, and I'm happy to be talking when he's chairing the session. So it was an elaborate and a beautiful talk by Dr. Sandeep Nair sir on how to try to prevent complications as much as possible. But I'm very sure that the more you do, the more likely that you will witness some complication happening, and you should be in a position to tackle these complications, identify them timely. That is also very, very important. So identify them timely and then manage them appropriately. These are the two things I would say. So this is something which I always say, that whatever we do, the patient should not be harmed. Even if the procedure is not successful, it is okay if the patient is alive and doing good. As Dr. Nair sir has said, this is a procedure which is not considered a very high risk procedure, because the complication rate, the rate of serious complications is very less than 1%. We have a lot of studies. This is one large meta-analysis. They shown that 15,000 procedures, you have only 79 major complications. This is a low rate, but nevertheless, if you're not careful, then you still can have major complications. So when can we get more complications is when you try to do therapeutic work. This is again very logical, but then I would want to say that when the more therapeutic work you do, the more likely that you will end up seeing complications. This is one review of one center, 2,000 procedures. You can see that the diagnostic procedure complications are 0.2, and when it is therapeutic, it is almost double the rate. With this brief, I will start with the individual complications. So I will not talk about the anesthesia-related complications, but I will talk about the procedure-related complications. So what can go wrong? A brief slide, similar slide was also projected by the first speaker. So what all can go wrong from the time we start incising and puncturing and creating a tract? So the first procedure I would like to talk is the lung laceration. So this is something which you should all be aware of. So two videos, you can see the one on the right here, you can see a nice deep lung laceration which has happened in the lung when we were trying to introduce a rigid trocar. So these two videos are not from our center, got it from our friends. This is from our own center. This was done a couple of months ago. It always happens when you teach, when you have trainees doing the procedures, and when you do not do the blunt dissection properly. You can see this is the lung, and directly below the place where you have incised, when you puncture it, you can end up having a very deep lung laceration there. So what is important is that you have to identify it well. So if you do not identify this lung laceration and you put a thoracoscope in this thing, then it is going to become even bigger. Luckily, that time it was identified. So why does it happen? It happens when you do not do the dissection well. So it always, as Dr. Nair sir has said, the dissection has to be with the forceps Blunt dissection, if required, do with the finger. And once you puncture the pleura, let air go inside if you do not have enough air, and then only put your trocar. More common when you're using a metal trocar with the rigid scope, and less often with the flexi-rigid scope. Now, the problem is, see, this is slide on prevention, as I have said. How to manage it? My talk is on managing. Well, luckily, as if it is very important to identify it on time so that you don't widen the laceration more. So most important, the crux is to identify the laceration. Second, if it's a small laceration, luckily we have had 1 or 2 lacerations in the last 8 years, and all of them usually heal well. So you don't touch the laceration much. Even if you have a laceration, you can finish off the procedure by just bending the thoracoscope and doing the rest of your work. If it's a small laceration, not much of bleeding, not much of air leak, then we can just be conservative and it usually settles. With time, the lung does expand. But if it's a large laceration, there's a lot of bleeding, a lot of air leak, as Dr. Nair sir has said, always better to have a good rapport with the surgeons and involve the thoracic surgeon. So they will be able to put a mesh or a glue or do a repair of this lung laceration. But till now, whatever we have seen, they were all small and they had settled. The second thing which we have to anticipate and be ready to tackle is the bleeding. So when all can a major bleed happen or significant bleed happen? While creating a tract for putting the trocar, while taking a pleural biopsy, or while trying to break vascular adhesion. So each of these areas, how to manage. These parts, I think I will not talk because already been covered. Now management is. So when we have a bleed while creating an incision, doing a nick or blunt dissection, it is usually mild bleed. 99.9% of the times, if you just apply consistent pressure with a gauze, it will stop. In case it is not doing, you can take a bipolar cautery and then cauterize those small bleeders which are there. Second thing is the bleeding while taking a pleural biopsy. This, as Dr. Nair sir has rightly said, you can prevent by taking biopsy over the rib and not in between the ribs. But sometimes you still can have bleeding. It is important to identify the bleed promptly. And then the most important thing is to apply pressure. You have your thoracoscope there. You just take a gauze which is dipped in adrenaline, dipped in tranexamic acid, or with nothing, just the forceps itself, close, and then whichever is the bleeding point, just apply consistent pressure. Wait for some time, and majority of times it will settle. If it doesn't settle, you might have to resort to using an electrocautery coagulation. So one video was also shown by Dr. Nair sir when he was saying, this was a video courtesy Dr. Arjun from Coimbatore. So this shows a relatively okay procedure being done, and biopsy was taken, and then immediately you can see that there was a small bleeder. The problem is once you take out this scope forceps and then put the forceps back, that is when you realize that things are going wrong. Same thing has happened here. The moment you go inside, you can see it's all red. You can see the sputter which is happening. This was again intercostal artery sputter. So these sometimes do happen. Majority of times it's a small bleed. The first thing you would want to do is to apply pressure. So this is what is being done. Take a gauze and then apply pressure. And then think what has to be done. Get your accessories ready while applying the pressure. So if the pressure alone is not stopping, and then you have to resort to an electrocautery. Can be done through the port, but if you can have a second port, it is always better to have a second port for doing this electrocautery. The third time where bleeding can happen is when you're trying to break thick adhesions. So when we doing adhesiolysis, it's always important for us to assess the nature of adhesion. Sometimes when they're very thick, you're likely to have vessels traversing them. In such cases, prevention is always better. If you don't want to touch it, it is okay. Or if you have to do, you always do adhesiolysis using electrocautery. That is about bleeding. Then is the pain. Pain is, of course, the most common complication of thoracoscopy. I think up to 40 to 50% or even more, the more will have pain during or after the procedure. This is usually a non-life-threatening complication. There will be a large inter-subject variability. And this is one article from PGI Sajal's team where they have shown that the pain is more with rigid as compared to flexi. This is very obvious. The rigid scope is larger. The pain after procedure also, 40 to 50% of them will have significant pain. Now, how to manage this pain? There is no guidelines, no definite guidelines, but then it is always important for us to improve the comfort as much as possible. And as logic says, the maximum pain will be with the conventional rigid scope, lesser with the mini rigid, and least with the flexi rigid, because flexi rigid, you don't have to angulate the scope. The trocar is fixed and the tube angulates, the scope bends and angulates inside. Now, what all can we do to alleviate the pain? Local anesthesia is something which majority of us do. Now, many centers are taking the help of anesthetists and giving regional blocks. So we can give intercostal block, you can give paravertebral block, you can give erectrospinal block. All of these blocks significantly improve the pain which is experienced by the person while during the procedure. And always you top up local anesthesia with sedation. So if you have an anesthetist with you, then definitely it will make the procedure more comfortable to the patient, but it is not essential that you will have an anesthetist always. Now, again, pain during trocar insertion can be very well controlled by good topical anesthesia or regional blocks. Sedation will give additive comfort. Pain during rigid scope manipulation. So rigid scope is a rigid scope. So when you put the trocar scope and then manipulate on both sides, you are likely to press upon the intercostal nerves and that will cause pain. This also can be alleviated by good local anesthesia and a regional block. Then pain while performing pleural biopsy. Parietal pleura is a sensitive structure. This is something which cannot be alleviated by the local anesthesia or the regional blocks. You would require a sedative to ease the pain. And pain post-procedure, again, it's usually a combination of paracetamol, NSAIDs, opioids, anything you can use to decrease, to alleviate the pain. The fifth thing is the pain post-pleurodesis. So if you do a talc powderage, again, that can cause pain because of pleural irritation. That again is usually managed with either opioids. Now it is said that you can also use NSAIDs after pleurodesis. The fourth thing is re-expansion pulmonary edema. This is something which we should be prepared, especially when we do thoracoscopy for a person with a massive effusion or a long-standing pneumothorax. So this also, as Dr. Nair sir has said, it is important to prevent it. This can be prevented by, as has rightly been said by the previous speaker, by draining a significant amount of effusion one day before the thoracoscopy, so that you won't drain too much on that day. Second, allowing air to enter. As we decompress the pleura, as we remove the fluid, we allow air to enter the pleural cavity. Then if you have a very large pleural effusion, the other thing which we also do is, we don't want to drain the fluid in toto. So the moment half of the fluid is drained, if you are able to see the pleural abnormality, you take the biopsy, put a tube, and then slowly decompress the pleura later. So re-expansion pulmonary edema, can be identified by coughing, vigorous coughing during the procedure, after the procedure, breathlessness, hypoxemia. Management is predominantly conservative. All of us know that it is usually self-resolving. You have to give them oxygen, you can give them BiPAP support. Very, very rarely the patient might require invasive ventilatory support. But as of now, whatever we have seen, most of them were managed with an NIV, and usually they improve in a day or so. Trapped or entrapped lung, this is not a true procedural complication, but this is something which can happen. One of the intent of thoracoscopy is that you want to drain the fluid or the air and want the lung to expand. But for several reasons, the lung may not expand. So this is called as the unexpanded lung. So it can be because of several reasons. Because of pain, the person is not breathing well, so it didn't expand. There might be an proximal endobronchial obstruction which you have missed. There can be a visceral pleural rind. This is a problematic thing. Or the lung itself is diseased. So how do we manage? How do we prevent it? There's no way to prevent. You can anticipate them. The CT can show a thick pleura, lack of ipsilateral, lack of contralateral shift. All of these you can sort of anticipate it. Management again depends upon the cause. Good analgesia, good breathing exercise, treating the underlying disease. All of these to some extent will help. Negative suction also we use sometimes, and it works, not always, but sometimes it works. If this is one case where there was an unexpanded lung, suction was applied and slowly over a week it has expanded. Then there is something called as medical decortication. This is something again which I will not tell the beginners to do. Not everybody should do. As Dr. Nair has rightly said, in a thoracoscopy, we should limit ourselves to the parietal pleura as much as possible. Lung is predominant to the surgeon, but nowadays the boundaries between interventional pulmonologist and the surgeon is becoming indistinct. So there are a couple of centers across the country who are doing this sort of decortication, where they gently identify the pleural rind and then peel the visceral pleura off so that the lung expands. This is called as medical decortication, but however, I would not say or encourage all of the people who are beginning thoracoscopy to do it, but this is just something which is being done. Again, before I end up, the surgical site infections or empymas. This is a very, very, very preventable complication. And it speaks a lot about the sterility. So this leads to a lot of morbidity and cost burden. The way to prevent is to be as clean, as aseptic as possible, to minimize the chest tube duration as much as possible. And whenever possible, try to remove the tube within the hospital. Don't send the person home with the chest tube. So earlier, when we used to send home, many people come back with either local infections or empymas. Whether an antibiotic before the procedure will prevent it, there is a study by Dr. Sehgal who has shown that pre-procedure antibiotic may not prevent post-procedure empyema or an infection. Performing in OT versus bronchoscopy, wherever it is, you have to be very, very sterile. So this was the RCT I was talking about, where they have received one dose randomized, did not prevent an infection. Treatment of this thing again is to identify it promptly and treat it with good, adequate antibiotics, and that's it. Now this is about complications, pain, bleeding, unexpanded lung lacerations, infections. These are all the things which we should anticipate and which we should know how to manage, and re-expansion edema. Last couple of slides about how we can make a procedure more comfortable, less riskier, is to minimize the stay in the hospital as much as possible and minimize the duration of the chest tube. The lesser the number of days chest tube is inside, the lesser is the pain, lesser is the chance of an infection happening. So nowadays, what people do is combining multiple procedures. The same procedure, you do thoracoscopy, you're thinking of malignancy, you do pleurodesis. Many centers, they put IPC also in the same sitting, and then they send the person back home on the same day. So now the evolving concept of daycare medical thoracoscopy. So this is also being done in some centers, and we also do daycare thoracoscopy once in a while. Today also we had a patient where the pre-test probability of malignancy was less. It's a diagnostic procedure. You do the thoracoscopy, take a biopsy, ensure all the fluid is out, ensure the lung is expanded, remove the tube and send the person back home. So this is the way daycare thoracoscopy can be done. So there is a lot of data from outside India, and some centers are doing it in India also. So when can we do this daycare thoracoscopy? Is when it is likely to be a non-malignant effusion, when there is not too much of fluid, and when the patient can be followed back whenever possible. So this is in brief about the talk. Already it is 9:40. We need to have time for panel questions also. So just to summarize the talk, thoracoscopy is a safe procedure, but I will say complications do happen. Majority are mild, but sometimes they can be major. It is very important for us to know what can go wrong, why it can go wrong, identify them properly, and manage the complications well. And lastly, shorter the hospital stay, the happier is the patient. I think with this, I will end my talk, and I will hand over to Jayachandra sir for taking the panel discussion.
Thank you very much, Nagarjuna. You kept your time, and I'm sure we are able to schedule everything around that. There was a little time overrun by Sandeep. I don't blame him. He was very elaborate, very, very comprehensive. You stuck to your thing because most of it was covered by Sandeep earlier. So I think it made your job easier. But anyway, I think we are going as per the schedule now. I think we have done an excellent job in covering up the procedure itself, anticipated complications, management of complications, and everything else. Now we come to the more interesting part of the entire thing. So we're going to have a panel discussion. So wherein, we'll have a group of people who are going to talk about all these procedures, and we'll take questions. And for the panel, we have Dr. Vijayanaran Tyagi from Lucknow. He graduated from Lucknow and now he's practicing in Meerut. So I don't want to read up the entire thing and take up more time on introducing him. So let us get on with the thing. And next we have Dr. Ganesh Vatambar. I think he is from Nanded. He's another person who's been doing all these procedures. So what we're going to have now is a hands-on experience of multiple people who are going to be talking about all these things. And then not the least, is Dr. Sonam Solanki, who's also been trained in interventional pulmonology, and I believe with Dr. Rajiv. So I think we're going to start off with a panel discussion. The panel will mean both the speakers who spoke earlier, plus the three other people who have joined us now, and I think we can go on. Now, let us have a series of questions. I think that is what is going to be most important right now. So, shall we start off with the questions? And I'll start with Dr. Ganesh. Can you please name the common and uncommon complications that you see in your practice? Practice meaning, everything related to thoracoscopy.
Good evening, sir. Sir, first, if you do proper examination of the patient and if you go through details, all the investigations, the chances of complications are very less. But still, if your luck is not good, it is going to be happen. For the easiness, the expected complication of medical thoracoscopy, it is divided into under three banners. Before the procedure, during the procedure, and after the procedure. Before the procedure, the first common is the hypersensitivity reaction to the local anesthetics. Chances are there. There may be pain during pneumothorax induction. There may be pain during trocar insertion. Shortness of breath after pneumothorax induction, chances are there. And very rare 0.2% chances of air embolism. Now, second.
May I interrupt here, Dr. Gautam? See, these are all which have been covered by Dr. Nair and Dr. Nagarjun.
Yes, sir.
Let us talk about personal experience. Let us make it more one-to-one rather than, the theoretical aspect of what can happen and what you face. What do you face generally when you're doing a thoracoscopy, and what has been your, bad experience? Where did you really find it very convenient to do it? Let us share your personal experience. The theory is all there for us and it's already been spoken about. Okay, sorry for the interruption, but now go on, please.
Sir, any procedure before giving that anesthetic, I do a sensitivity test. That's why the chances of local anesthesia hypersensitivity reactions are very less. The second thing, main common complication during the incision and that trocar insertion and during the insertion of thoracoscope, the main complaint by patient is the pain. The pain chances are much more there, and sometimes you will get a little bit fall in the oxygen saturation also. Till now, I have not come across the air embolism complications. This is the beginning before the starting of the procedure. The main common I stuck up with the pain only sometimes.
Okay, I think you made a very valid point. I think it's very, very important that you anesthetize this the portal entry, absolutely pain insensitive by using a generous quantity of xylocaine so that you make it a painless procedure for the patient. Sedation always helps, no doubt about that. I think you made a very valid point there. I think let me ask Dr. Vijay about this thing. Do you see any difference in complications that you see in rigid versus flexi-rigid?
Okay, thank you, sir.
The advantage of either of those things. I don't know which instrument you use, what your experience is. Please share with us. Thank you.
Using thoracoscope since last 22 years, but initially I was with semi-rigid and flexible semi-rigid. But after 2 or 3 years, I shifted to rigid only because 20-25% of my patients were being shifted from semi-rigid to rigid. There is a limitation with semi-rigid. Of course, it's safe. The trocar is safe. And initially, we were not very it was not very well trained in India. There was not any training programs, but where I did my senior residency, there was a surgical backup. So we had done some and assisted some thoracoscopies there. So ultimately, if you want to see inside the pleura, your semi-rigid is excellent. It will go everywhere, even pericardium, your diaphragm, your apexes are very well seen. But if you want to do something, it is always better to go with the rigid one. And complications with rigid one, I understand is more. But by the time you experience, I don't feel ki it's a procedure of complications. It's a very safe procedure. I do not do any of the any anesthesia because initially for 4 to 5 years I used anesthetic with me, but finally there is no anesthetic, there is no assistance. I do with my own assistance, so I can give you very practical and very uh, precise in remote areas where you don't have this multi-specialties, hospital multi-specialties people, what to do and how to do.
Yeah, there's only one word I'll catch on to. You said when you want to do something. What do you mean do something in thoracoscopy?
Biopsy, or you want to remove adhesions, or you want to do any further procedures inside the pleura, then you need with rigid thoracoscopy. Else, otherwise, I am not very happy with the semi-rigid because it's safe, of course, but biopsy is not very good.
So the point is that when you want to do therapeutic work, you would prefer a rigid thoracoscope. I think that's the point you're trying to make. Fair enough. I mean, I think that's good. So now what do we have? Now we're going to have this old lady in the panel who's going to talk about it. How much fluid can you drain once you enter the pleura? How commonly do you see re-expansion pulmonary edema during thoracoscopy? And how do you do anything to prevent it?
So thank you.
Let us go on with what instrument do you use?
So I use a flexi-rigid thoracoscope.
Okay, fair enough.
I think this has been covered in both the talks that yes,
True.
it's a common side effect that we see. Since you mentioned we are sharing our personal experience, so no, I have not seen any re-expansion pulmonary edema. Maybe because we are just starting, the practice of getting the reference. Most of the patients we get have either been drained or they already have a pigtail or a tube. It's an undiagnosed effusion. Those are the common indications we get. In fact, we commonly, what Dr. Nair had mentioned, we have to instill saline to create the minimum space of 2 centimeters through the pigtail. We've had to do that very commonly in our patients. And it's been mentioned in the previous talks that you be patient. Once the trocar is inside, let the lung collapse. Even when the fluid is coming out, let it expand, because anyways you need a plane between the lung and the pleura while we are doing our thoracoscopy. And the two common things that have been mentioned is that you can tap some amount of fluid a day prior, or don't evacuate. A very practical thing that Dr. Nagarjuna mentioned, that don't evacuate completely the fluid. Let just enough space for you to do your biopsy, leave the tube and let it drain slowly.
Excellent. But there's only one point I would like to interject. I mean, it's my privilege as a moderator to talk about this. When you're using a semi-rigid, right? You're using a quad, you're putting in the scope, it is not a closed system. So when you're aspirating from the pleural cavity, even if you drain out 1.5 liters, 2 liters at one time, because it is not a closed cavity, you are not creating a negative pressure in the pleura. So the chances of you having a re-expansion pulmonary edema do not exist. This will happen when you're using a rigid thoracoscope and it's a closed system and you evacuate large volumes of fluid, then you have a problem of re-expansion pulmonary edema. There also, if you have been trained appropriately, after you drain about 700-800 ml of fluid, you let in that much of air with the side port before you drain the fluid. Equalization of the pressure in the intrapleural versus the atmospheric pressure reduces this complication. I'm glad you didn't have any problems, but occasionally when you are a little more over-enthusiastic in doing all these things, you will encounter these issues. Okay, I think that was a great this thing. I'm glad you didn't have any problems. So let's get back to Dr. Ganesh. What steps do you take to prevent any bleeding?
Hello.
Yeah, go ahead.
So for preventing the major common complication, which is the bleeding, the proper detailed history of the patient and examination is must first. And history of addiction, especially chronic alcoholic patient, if it is there, we have to take proper history. And to look after for chronic liver disease is there, we have to look after for that. And as per that, we have to do some blood investigations also. And detailed preceding drug therapy, in particular of anticoagulant treatment, we have to take detailed history for that, which may be a absolute or relative contraindication before doing that medical thoracoscopy. More severe coagulopathies like hemophilia are the contraindication for medical thoracoscopy. The risk of bleeding is very high with renal insufficiency, CKD patients, and elevated creatinine patients. In such a patient, we have to do with very precautionally to take the decision to go ahead or not. Special precaution always to be taken in severe liver disease, cancer patient, chronic illness is there. And the proper blood investigation I do before doing any thoracoscopy. The basic CBC, the platelet should be always more than 1 lakh. The bleeding time, clotting time should be normal. INR should be less than 1.2. And his LFT and KFT should be normal. And if patient is on tablet, ecosprin or clopidogrel, we have to stop 3 to 5 days prior to the procedure. This is for pre-doing procedure. And during the procedure, some precautions should be taken while doing that to prevent the bleeding.
That has already been discussed threadbare.
The
I think your point is very well taken. There's only one additional thing that I would like to add to this. Any person who has visited a cardiologist, make sure that he is not on clopidogrel. Just look into the drug list. I will tell you the number of times you face that on the table before you anesthetize him, you're just checking up the drug list, you find that he's on clopidogrel. God knows for what reason. But make sure that he has not had a cardiac consult before he has come to you. Okay, that's besides the point. Anyway, let's go back to Dr. Vijay. Let's say you take a biopsy and you nick a vessel. Did you have this issue? And how did you control it?
Actually, it was already been discussed, but usually vessel which bleeds is the arterial, and artery is a muscular vessel. So it's not a difficult task to stop it unless you don't have to. You have to do a pressure. You have to take some adrenaline and put a gauge piece on that. If it is filled, of course, you have to do a cautery. These are intercostal arteries, and these are very, very highly vascular. And you see before doing a biopsy, usually you see if it will bleed or not. If it is safe, yes, you go ahead. And regarding that INR, we do it at 1.7 is our cutoff. We can do it 1.6 also.
Which one would you consider more serious, an arterial bleed or a venous bleed?
Venous bleed, I suppose, is very serious.
I think that's a point I wanted to just elicit from you. Because the venous bleed, it just keeps on oozing. There is no
way.
Nothing to prevent it from stopping. You will need to do something about it. So a venous bleed, because of the lack of support of the muscular structure in the vessel itself, tends to bleed much longer, and it is more difficult. Once you remove the gauze, again it will start to ooze. So be careful. Probably you'll require a electrocautery or something like that. This is one point which I just wanted to mention. So, Dr. Solanki again, how do you avoid pain before, during, after thoracoscopy?
Right. So again, this has been discussed, but I mean, we cannot emphasize this enough that giving a good local anesthesia everywhere, right from the skin up to the subcute, the muscle, to the pleura. Use dissection, like sir, you mentioned, the more you dissect instead of cutting, the incision should just be at the skin level. That we are lucky to have our anesthetist with us, so we do use sedation Post-op pain, so and during the procedure, it's very important when you're maneuvering the instrument not to tug on the skin too much. You have to be very conscious about that, because very often you're continuously looking inside and the pleural cavity, you forget that you're pulling on the chest wall. The decision of topping up the sedation, generally at our center the anesthetists take. Post-operative analgesia generally is very well managed with NSAIDs. We use paracetamol or diclofenac routinely. Very rarely we've needed opioid analgesia. And post-op, if you look at it practically, after the procedure is done, the patient is with an intercostal drain, which we routinely do in our practice. So that pain is managed the way we manage post-operatively pain. In the literature, they've described epidural pain, but those, I mean, at least practically, I've never seen that we need to step up.
Fair enough. Fair enough. Sandeep, the great question for you. What happens when you put a port straight into the lung, and how do you manage it? I'm sure, Nagarjun has already talked about it. Have you had any personal experience on this? And what did you have to do?
So fortunately, sir, I never had the experience of puncturing the lung. Though I use rigid in most of my thoracoscopies, but fortunately never use it, because we take a full care of having enough pleural space before we enter. For being fortunate, but in case if it occurs, because if it occurs, already it has been covered by Nagarjun,
Yes.
also to take up on it.
So,
One thing we are
it just shows that
Yeah,
you have
no,
been
no.
thoracoscopist.
No,
Never had
no,
this.
but one thing I would say that I'm lucky. I'm lucky to be working in a multi-specialty hospital. See, most
Not
of the thoracoscopy occurs in when you do it during daytime. It's not a night procedure, emergency procedure most of the time. So we have a surgeon standby with us. So in case, God forbid, if ever occurs, and if I'm not able to take it, working in a multi-specialty definitely helps you by calling a surgeon if at all I require it. But I'm very fortunate not to do it. I've been taking just to put a one point more for it. That is that whenever you're putting a trocar, rather than pushing it, it should be a guided way, and it should be screwing the corkscrew method. So, like I said, you know when to stop. Not only the procedure, you should also when to stop that going inside. The sudden giveaway should not go it keep on going it. So if it's these small things you keep in your mind, you will prevent it.
It just talks about your skill in doing the procedure and placement of the port. That's good. Great, Sandeep. You didn't have this problem. Nagarjun, next. Would you risk biopsies from the diaphragmatic pleura? How do you do them without causing any damage to the diaphragm?
It's a very interesting question. So first is the need to do a biopsy from the diaphragmatic pleura. I would say that if you have a disease which is there on the parietal pleura and the diaphragmatic pleura, I will not touch the diaphragm at all. So in the last 1,000 odd cases where both in PGI and here where we have done thoracoscopy, I can only remember 1 or 2 instances where we could find a nodule on the diaphragm and nowhere else. I think that will be a very, very rare circumstance.
Yes,
so I think the first thing I would say is that the need for doing a diaphragmatic nodule biopsy is very, very rare. So in those 1 or 2 cases, we used the smallest possible forceps and very carefully took a biopsy from that forceps. We didn't get a diaphragmatic tear in those 2 cases, but I will not tell that 2 cases is something which I can tell that this has to be done. So what I will say is that we will try to avoid it as much as possible.
Fair enough. I think that's a fair point that you made there. Now, going back to Dr. Vijay, what issues can you face when you're doing a thoracoscopy for a very obese patient?
Okay.
What are the pitfalls to stay away from that?
It's a very good question. Actually, I do not give any anesthesia to these patients. Position is important. Normally, I go at anterior axillary line and I go slightly upwards from down. So you have plenty of space. Your lung is clear. I do not give any type of anesthesia, only local, and patient is counseled very well. If at all, usually I give paracetamol with tramadol infusions. I've done few studies with dexmedetomidine and ketamine, and I think 2 separate arms was taken, but there was no difference because these patients are risky patients. If they land up in respiratory failure, it's very difficult to manage and to intubate also.
Absolutely.
And point I want to highlight, about insertion, we have a very safe technique. If you go inside slightly up to the pleura, you can incise up to the pleura. After that, I use my finger. I use my finger rotatory. If I go inside and touches the lung, I leave it, let the air go inside. Then I again reintroduce my finger. Then I see your lung is not there. Then I introduce the trocar. I never introduce the trocar without palpating the lung or without going inside the lung with my finger. If it is a tight, I go with my little finger, else otherwise my index finger. So it's a very good habit. But somehow for last 10 years I am using it and no trauma at all. So this is the best way to go from laterally, from anteriorly to posterior, from down to up.
Yeah. Sometimes the port for a semi-rigid is too short to reach the pleural cavity. These are the issues that you would contend with every now and then. Then, on the job, you have to find out what is to be done there. Okay, Dr. Ganesh, can you tell us something about the mediastinal emphysema during thoracoscopy? Have you had any experience on that? Otherwise, we'll skip that. It doesn't matter really, because it's one of those rare things that you.
It's very big complication, and I never came across this complication by the grace of God. Yeah. And it is mainly due to faulty position of trocar in wrong passage, or due to sometimes biopsy of mediastinal pleura, or sometimes forceful ICD insertion.
These are all no for a interventional pulmonologist. Don't try the mediastinum. Don't touch the diaphragm. All that is fine. I think great. I think you have answered the question there. So, Dr. Sonam, how would you like to define a prolonged air leak post-procedure, and how would you handle it? The question again, there's a rider. Why would anybody get a prolonged air leak if you have not touched the lung? Okay.
Yeah. So I think these are, like you mentioned, very rare complication. If you really, like a lung laceration, what we just discussed, could, have a prolonged air leak where you're in the ICD getting the leak till day 5 or day 7. And personally, I've not come across these things, and I don't see the management being any different from the way we manage the surgical prolonged air leak.
Absolutely. Now, going back to Sandeep now. In your experience, have you seen a post-procedure infections? How often? How do you prevent it? I think you've already spoken about all these things at length in your talk itself. That, you're entering a sterile space is different from a microscope.
So infection does occur. It's not that I've not seen any infection after the procedure. Infection does occur. Actually, we have a same room where we do bronchoscopy and the thoracoscopy, and comparatively, thoracoscopy needs a more sterile atmosphere as compared to the bronchoscopy. So whatever we do, we always try to do thoracoscopy as our first care, then do bronchoscopy subsequently. So many times you have infected bronchoscopy, doing it bronchoscopy in the same suite. So because we do in the same suite, the bronchoscopy as well as the thoracoscopy, of course, after cleaning the everything and fumigating it. But still, and so I do thoracoscopy as my first case, and then do my bronchoscopy subsequently. But still, there can be a one-off case as an infection, and we normally do give antibiotics, despite the literature might say might help it or not help it pre-op. I give a shot of antibiotic pre-op once and then continue for a day or so. And in case it's already in PIMA when I'm doing it, so I don't do another sterile patient in the same sitting without really cleaning the whole setup, because you might push in one infection to the other. So with the proper precautions and whenever we are cleaning it, we should be properly cleaned it out, draped it out. Then definitely you can prevent it. And many times, our colleagues, our the staff, which GDA, which will be there. So we should take care that they are not touching our gown or anything when we have done it and we're about to do. So these all these precautions when we take it, so I think we can really do away with the infection. But one-off case can still occur.
Yeah, fair enough. I think, having said that, statistics will catch up with you eventually, whether you like it or not. Okay, let's go back to Nagarjun now. What do you do if the lung doesn't re-expand? Is there anything specific that you do? You've already mentioned this. When you have an entrapped lung, there's nothing much you do except to do a IPC or whatever it is. But anything else you would like to add to that?
So I think we should and look at why we are doing the procedure. If it's a diagnostic procedure and if the lung is not expanding, then I think we should not be too worried.
Right.
Intent was to get a diagnosis, you take a biopsy, come out. But what everybody as can do is, if there are a lot of adhesions, try to release the adhesions as much as possible so that the lung will expand. But beyond this, if you are a medical thoracoscopist, I think that is where you should stop it.
Stop.
Though there are people who say that I would want to do a visceral pleural decortication, I personally don't do it. And that is only for the select few like Jayachandra sir or some centers who do those things. But by definition, a medical thoracoscopy is a single port thoracoscopy where we touch the parietal pleura, not the visceral pleura.
Absolutely. I think you
Good.
nail on the head straight away. Dr. Vijay, how common is air embolism? Have you encountered any cases?
Yeah, it's not very common. I feel the only cause is either going inside. You can traumatize vein. The air can go inside, and finally with azygos with IVC, it can go inside the heart. That is the only major complication it can occur.
You have never faced it yourself.
Yeah, I have not seen any complications like air embolism.
I think fair enough. So, Dr. Ganesh, have you ever seen seeding of malignancy after a thoracoscopy? In which conditions? Any precautions that you would like to do to prevent this kind of seeding?
Till now, I have not seen a single case also.
Fair enough.
Maybe
Fair enough. I mean, let us skip that and go ahead.
commonly
Except to say that,
treated with mesothelioma cases, and in my area, the mesothelioma cases are not here.
oh, okay, I've had enough people talking about mesothelioma causing the seeding and having a post-operative radiation into the port area and other things will prevent all these things. I don't think any of us have had so many cases. Anyway, once we finish diagnosing a case of mesothelioma, it becomes an oncologist's job and they never come back to us. So we really don't know how many people we have really seeded along the track. So I think we are lost on data on there. Okay, let's talk to Sonam now. Thoracoscopy is a relatively safe procedure in expert hands. Are there any chances of mortality? What could be causing that? Have you had any mortality during your cases?
No, sir. I mean, and this is one way I would hope the statistics don't catch up with me and my patients,
Sure.
but no mortality. And from all the complications that we've discussed, I think one thing that comes across that if we are not prepared to handle complications, that could be one of the causes of mortality. Like you can encounter bleed if you don't have what Dr. Sandeep mentioned, the team knowing who has to get the blood, who has to, all those precautions, what we've discussed. And personally, I have not seen any mortality, and bleeding seems to be, and like we've seen that the mortality is less than the transbronchial lung biopsies that we routinely do.
Okay, I think that's a fair point. I think none of us have had direct or immediate thoracoscopy related deaths, but there are so many things when patient dies after a thoracoscopy within a week or 10 days or the ensuing 2-3 weeks before getting discharged after the procedure. These are still attributed to the procedure done. Most of the times when you're doing it for advanced malignancy, where you're having a malignant pleural effusion, you try to do that, they'll end up with some other issues which eventually cause their demise. And it could be remotely attributed to the thoracoscopy procedure done itself. So that is something that we need to keep in mind. Any death occurring immediately in the same admission after a procedure is related to the procedure done and not to anything else. I mean, that's how the system works in our country. So let us be very careful about that. So when you're counseling a patient, I think you need to tell them, stage 4 disease, advanced disease, we are trying to do something. It's only a palliation, so we don't know what's going to happen. I think that is one word of caution that I think all of us have to keep in mind before when you're counseling our patients. I think I've run out of questions. The prepared questions for the panelists here, I think there are a whole lot of questions that have come up from the audience. We'll try to take as many as we can. And what we can't, we'll say excuse and, talk to us personally on a WhatsApp group, whenever it is. and you can go on. So let me go to the questions. Can we use CO2 for inducing pneumothorax as it is routinely done during laparoscopies? Nagarjun, would you like to answer that?
So actually, in everybody has spoken at some point about insufflation of air, but once what I feel is that if the moment you incise, dissect, dilate, and leave it, automatically the air will go inside.
Absolutely.
So there will be very less chances that where you would want to insufflate. In fact, I have never done insufflation of air into the pleural cavity. What we normally do, we do a blunt dissection, create a tract, gently put the trocar inside, and then the air will go inside, pneumothorax will happen.
Yes.
So I think this is my experience.
I think a CO2 insufflator does not arise in thoracoscopy, except people who are doing a VATS procedure, surgeons who are doing it, they will use CO2 insufflation and do it. And mind you, we are not surgeons. So let us stick to our job of taking care of the parietal pleura and other things. Lung doesn't come under our purview, so let us not handle that. Unless, of course,
and if I may add, sir.
Yeah.
If I may add, sir, many of our patients are COPD patients, and we don't want to give CO2 in any way to these patients. So even in the pleura, I would say, just open it to the atmosphere, suck it in most of the places, and nothing has to be done. We don't have to insufflate anything in the pleura as such.
And I'll just add one thing, sir. I was actually talking to a surgeon. Also, when they do this VATS or whatever it is, what they have suggested is that they sometimes use CO2 to insufflate. The only thing is that the pressure which is kept when they insufflate CO2 in the thorax versus abdomen is that in thorax usually keep it at 6 to 8 centimeters.
Yes.
When
Yes,
in
right.
abdomen it is around 10 to 14. So you have to keep a low pressure CO2, else you may have a chance of embolism.
Absolutely.
Absolutely.
I think that's a fair point made. Achha, there's another question which has come up. Renal cell carcinoma, pleural deposit, taking a biopsy, bleed and all that. So somebody who required a VATS at the end of the procedure and other things. So any special precautions for a renal cell carcinoma when you're doing a thoracoscopy?
Renal cell tumor, they bleed a lot, because I have had renal cell, I've authorized it in intrabronchial tumors, lot of them. But in pleural, when I go and when these patients, when I do a biopsy of these patients, even there they also bleed a lot. So you have to be very careful when we are taking a biopsy from the renal cells. They definitely bleed a lot, whether it's intrabronchial or in the pleura. So when I always do whenever I do take a biopsy, first I take a very small biopsy rather than taking a big. I don't get carried away. Take a small biopsy, just test the water. Just see if it is not a vascular tumor as it could be, because we have not. And in fact, if the patient already has a history of RCC, then please don't take a large biopsy. And you can have to take it a very smaller biopsy and be very careful with a cautery always ready in your hand. And you may even have to do a 2-port if required, because they can bleed at times.
Fair point. The other thing is, what is the kind of cautery that you use? Bipolar, unipolar, what settings and all that? And maybe I will take an opportunity to answer it myself. See, using a bipolar is a nuisance. Most of the times when you're doing it in a thoracoscopy suite, you can use a unipolar, that is good enough. And most of the times all you need is a cautery forceps. You hold it. Most of the time it is good enough to take care of an arterial or a venous bleed or any ooze sometimes. Sometimes you have the spray cautery device wherein you put it and spray the entire area, the whole thing settles down. If you are lucky, if you are using it in one of those fancy bronchoscopy or a thoracoscopy suite, probably an APC will help in case of a diffuse bleed. You can use all of these things or any of the above in any combinations. So let us go on to any role of diuretic steroid in re-expansion pulmonary edema. Anybody can take that. Sonam, you can take that.
Right. So most of the times, hypoxemia is there, and you need supportive treatment. Very rarely, it has been mentioned in the literature. In very severe cases, you can use steroid or diuretics. But I think that is only after you have done the protocol of giving oxygen, supportive care, and NIV.
Sir, I'll just add one thing. It's another complication. See, re-expansion edema is a type of pulmonary edema. We've also had patients who develop Takotsubo cardiomyopathy, stress cardiomyopathy after a procedure. So basically, that is another thing which we should keep in mind. And unexplained cardiac decompensation, pulmonary edema post-procedure. Always think of Takotsubo or an acute coronary event also.
Okay. What are the pre-medications that you would prefer before thoracoscopy?
Dr. Ganesh is trying to say you have to unmute yourself.
If you unmute yourself, then
Ganesh, unmute yourself.
Yeah, it's not mentioned anywhere, sir. If atropine is useful or not, we don't know anything about it.
Do any of you people use that?
No pre-medication is required. Ideally, you go for
No atropine. No atropine before the
no
procedure.
atropine. No atropine. It can cause tachycardia. And just like in bronchoscopy, we are not using atropine. No thoracoscopy, we are not using atropine. So no specific pre-medication. Only thing is the night before you should be sleeping not. So at times if the patient is anxious, a night before you can do.
Let's put it like that. We want somebody who's not anxious, anxiolytics, probably mildly sedated. If you can give him a little bit of amnesic effect, nothing like it, give adequate this thing. Don't dose him fully. Give him small aliquots. Keep him comfortable all through the procedure. The moment you do that, just stop the thing and he wakes up comfortably without having any memory of the procedure done. That's fair enough. Okay, now again, people are getting back to cryobiopsy. What is the role of cryobiopsy in taking a biopsy? I mean, very fancy tool for it, taking a biopsy from the pleura. Nagarjun, yes.
But I'll tell you, because there has been a lot of interest and research on cryobiopsy. But if I have to answer, cryobiopsy doesn't score anywhere above a rigid biopsy. If you have a rigid thoracoscope, that's the end of it. The cryobiopsy has no role. Now, where does cryobiopsy have a role? That if you do not have a rigid scope, you have a flexi-rigid thoracoscope, but you have a cryoprobe. So that is only one scenario where I can imagine where if you're not getting good biopsies with a flexible forceps, that you might think of using it. But other than for publishing, I don't think if you have a rigid scope, cryobiopsy has a role.
Yeah, try taking a cryobiopsy from a mesothelium.
Nagarjun, just I want to ask one thing.
Yeah.
The advantage of using cryo, if it is useful for the stoppage of bleeding?
Cryo, in fact, will cause
Chances
more.
of bleeding are more with forceps biopsy.
It is nothing to do
On the
with.
contrary, cryo will cause more bleeding when you pull it out. It will cause greater chunk of the pleura will be taken out and will be causing more biopsy because as soon as it goes away, effect goes and it starts bleeding. So cryobiopsy is only to get a bigger chunk, but I totally agree with Nagarjuna. People like us who are using rigid thoracoscope more often, we are much more comfortable by taking a larger chunk with a rigid thoracoscope. I don't know why cryobiopsy will be done if I'm doing a rigid thoracoscope, and my patient can tolerate it very well. So I'll go for rigid and.
Okay.
In fact, I have another bad experience with cryo. So when we were initially doing flexi-rigid in cryo, so it was in flexion. The cryo was there. We froze and pulled it out. So actually the scope also got damaged in that trying to pull the whole thing outside. So I think cryo is only an addition to a flexi-rigid thoracoscope, but it will never replace a rigid thoracoscope.
Fair enough. I think that is the consensus. I would agree with you. I'm one of those rigid thoracoscopists, so I think I entirely agree with Nagarjun what he's saying. The other practical point is how low the platelet count is safe for doing a thoracoscopy.
So I already mentioned that normally 50,000-60,000 platelets is, as per the literature says, that 50,000-60,000 is good enough to do a medical thoracoscopy. But again, I would say that you have to weigh the advantage of doing a thoracoscopy, or you can wait for 1 or 2 days and build up platelets to about lakh, you can always do that. But otherwise, 50, 60,000, some literature is 60,000, some 50,000. That's safe enough for thoracoscopy as per the.
The thing is, when you're dealing with renal failure patients, probably it makes sense to have some PRP ready if they start to ooze or something like that. Nagarjun, anything else?
That's aim is a platelet count and platelet dysfunction are two different things.
Different things.
So as far as the count is concerned, I will not say 50, 60. I will stick to 1 lakh, sir. So 1 lakh is what I will say is what has to be there, or else you be prepared with a SDAP or RDPs.
This is the point I was trying to elicit, saying that the absolute count of the platelets is not important. Platelet dysfunction also needs to be considered before going into the procedure. And it is usually seen in renal failure and other patients. So better be careful, better be prepared for all these kind of, anticipate these complications and keep some PRP or something like that ready before you do it.
Actually, sir, in our hospital, there's a big bone marrow setup. There's a big department. So there, if I tell them to have a 1 lakh platelet, it's very difficult at times. So what I'm saying, if you can wait, if you can really build up a platelet to 1 lakh, you can wait. Otherwise, even in these patients were required and we have not faced anything, and it's quoted in literature also. So that also is important for us when we do a procedure, and there's literature say 60,000, 50,000. So what I'm saying is that in case we cannot improve it in this patient and it is required by all means, then we do it. Otherwise, if we can build up the platelet to 1 lakh, it's definitely safer.
Fair enough. I think most of the other questions we have come in are not really related totally to thoracoscopy. So I think we can skip over some of the questions that you have. Now, again, saying about cryobiopsy and other things. So I don't think we need to do anything. How do you differentiate arterial or venous bleed on the OT table?
It's very simple. One is projectile ooze. It's very, very simple.
Look at the color of the bladder. Then that will give you an answer to what it is. I mean, we cannot comprehensively cover every aspect of thoracoscopy in a 1 hour or 2 hour discussion that we have had. But I will tell you one thing. Experience will teach you the most when you're doing it. I mean, Sandeep has been doing it for how many? 15 years plus, 20 years plus. He's been doing thoracoscopies. He's been doing so many of these things. And I'm sure he has seen it all. He's seen a little less than the usual run-of-the-mill thoracoscopist because he's been trained well. He's been trained how to do a proper thoracoscopy. Other people who have picked up thoracoscopy by attending a couple of workshops and trying to go in and do a thoracoscopy are likely to have higher list of complications than a person who is properly trained over a period of time. I think we have had an excellent session wherein the speakers have covered just about every aspect of thoracoscopy and complications, anticipation and management of that. I think we have had an excellent panel discussion with people talking about their own experience and what they have faced. I think we have had a fair amount of questions coming in from the audience also, which have been addressed. I think we have come to the end of the session today. I think anybody else to be free to have any. I think we have another 5 minutes or so. I think anybody wants to have a comment about the entire program, the panelists, the speakers, or Dr. Amita, if she's somewhere there listening quietly. I mean, do come back. I mean, let's have it.
Sir, I think I'll just add, I'll come back to what Dr. Nair sir has started off with, is that two things, to have a checklist. I think if you have a checklist, comprehensive checklist, and tick all the boxes, you can probably prevent 50% of the complications. Not every complication, but 50% of complications.
Absolutely.
Second thing, which again Dr. Nair sir has already said, is to take a informed audio visual consent. That these are the two things I think which are the crux, and we should never forgo these two steps.
Absolutely. I think you hit it as it should be. Informed consent, checklist. I mean, you can't take away from the merit of a checklist. I mean, all of us are busy guys. All of us are working. All of us are, you see the OP in the middle, you go and do a thoracoscopy and come back. The checklist will avoid, prevent multiple complications. I think you'll be spot on every time. And there's hardly a chance that you're going to miss out on something.
Sir, if I may add, sir, as an interventional pulmonologist, I said it before, I want to say it again, that we should know when to stop. Please don't get carried away. Your patient is getting hypoxic and you say one more biopsy, then that last biopsy might be difficult. So you should know when to stop. Secondly, don't hesitate to do a redo thoracoscopy if required, because it's not that you think that you have to do it today itself. There are some limitations. This pleura can be having disease somewhere may not be disease. There may be some adhesions. So you may have a negative outcome that there's the biopsy doesn't show anything. That's very common. So please don't worry. You may have to redo thoracoscopy. Plus, please stop when it's required. Don't get carried away. As an intervention pulmonologist, you should know your limitation, your Lakshman Rekha, your boundaries.
Absolutely. That is experience speaking. Thumbs up to you, Sandeep.
Thank you, sir.
Yeah, welcome, Amita. I saw you briefly and then you disappeared again. I think you could come back. And I think let's have a closure to the program today. I think we've had an excellent...
Yeah, actually, I was listening from the delegates link. And, when you said come in, I just came in. I'm thrilled to tell you all. Yeah, I just think the program was fabulous. I've been listening to everything. The talks were fantastic. I mean, really, I've learned so much. The panel discussion has been really very crisp, very to the point. And Dr. Jayachandra, you've been like really a great, great moderator, just driving everything right so well, I think just everybody, you were marvelous. Sandeep and Nagarjuna, too good. And all our panelists, Dr. Vijay, Dr. Ganesh and Sonam were just amazing. And I'm thrilled to tell you that we have 1796 logins even right now. 1,796 logins. That's our highest of the first 3 modules. We are very, very happy. The credit goes to y'all. And the best thing is that people are still logged in. So I think it's a perfect time to stop, Please stop when it's really high at the crescendo.
I had a great session.
Thank you so much. Yeah.
Every one of my panelists, the speakers, and Amita, you too, and AIB for taking the initiative of doing the entire thing, putting the program together, having a structured program, doing it properly, teaching the delegates as it should be done systematically, so that, you make them better interventionalists. I think you're doing a great job. Okay.
Thank you. I feel what is really special is that, in conferences, we just hear things for 20 minutes. Whereas over here, each talk is for 20 minutes and then there's discussion for an hour. So, people, the problems that they have get discussed, and maybe that's the reason so many people are joining in. And what is interesting is that we have a lot of people from medicine who are also joining. It's not just pulmonologists. There are lots of medicine people also joining in. So I think it's great,
We have a lot to learn.
No, but thank you so much. Fantastic show by every faculty. A huge big thank you to each of y'all. Y'all are shining stars and we are so proud of y'all. Thank you.
Thank you. Thank you very much. Thank you all. And big
Okay.
thanks to the delegates too.
Sorry?
Big thanks to the delegates too. All those guys who have been listening there for 1.5 hours.
I know. I'm going to put up on our group, I'll put up all the wonderful messages I've got, okay? You all will feel very happy. Yes.
Oh yeah, that should be good. Thank you
Great.
very much. Good night, all of you.
Good night.
Good night. Thank you so much.
Thanks.
Bye.